All right, let's talk about something we all do, thousands of times a day, without even thinking about it. Breathing. It's so fundamental, right? But what happens when it's not easy, when it's a struggle? Well, that's when a whole class of incredibly powerful drugs steps onto the scene. Today, we're diving deep into the medications that help fight the battle for breath. I mean, just try to imagine it. Try breathing through a tiny coffee stirrer. That feeling of not getting enough air? That's what millions of people with obstructive lung diseases face every single day. It's not just some small annoyance. It's a constant, exhausting fight for oxygen. So let's break down exactly why this happens and how modern medicine is designed to fight back.
So in this story, we have two main antagonists, two big players causing all the trouble. Chronic obstructive pulmonary disease, you probably know it as COPD, and asthma. At their core, they're both obstructive diseases, and that just means they block or narrow the airways, making that simple act of breathing incredibly difficult.
Let's start with COPD. Now, the one word I really want you to lock onto here is permanent. Unlike some other conditions, the airway blockage in COPD is chronic. It's always there, and it's usually caused by this one-two punch of two separate but very related conditions.
And this is a fantastic way to see those two conditions side by side. They're like two different faces of COPD. On one side, you've got emphysema. This is where the tiny air sacs in the lungs get destroyed, which traps old air inside. Patients have to work so hard to push that air out that they often look flushed, which is where they get the nickname pink puffers. Then on the other side, you have chronic bronchitis. This one's all about inflammation, damage, and tons of mucus, which leads to really low oxygen levels and can give the skin a bluish tint, hence blue bloaters.
Okay, and this is a fascinating and super important clinical detail. For most of us, a healthy oxygen level is, 95% or higher. But for a lot of COPD patients, the target is actually lower, between 88 and 92%. So why? Well, their bodies have gotten used to having high levels of carbon dioxide. So their trigger to take a breath actually comes from low oxygen. If you give them too much oxygen, you can actually shut down their natural drive to breathe. It's totally counterintuitive, but absolutely critical to know.
All right, let's switch gears to our second antagonist, asthma. Now, it also blocks the airways, but its root cause is totally different. Asthma is really an inflammatory and allergic condition. It's basically the body's own immune system going into overdrive, overreacting to a trigger, and, well, turning on itself.
So how does an attack actually unfold? Well, think of it like a set of dominoes tipping over, this chain reaction called the allergic cascade. First, you get exposed to an allergen, like pollen or dust. That allergen then bumps into and locks onto these little antibodies called IgE, which are just sitting on the surface of special cells called mast cells. That's the trigger. The mast cells basically freak out and explode, releasing a flood of histamine and other chemicals. And that's what causes the whole mess: swelling, more mucus, and that terrifying tightening of the airways.
Okay, so we've met the bad guys. We understand the problems. Now let's talk about the solutions. It's time to open up the pharmaceutical arsenal and look at the different kinds of drugs that are designed to jump into this battle, force open the airways, and quiet down all that inflammation.
First up, we've got the sympathetomimetics. Big word, I know, but just think sympathetic nervous system. That's your body's fight or flight response. If you're running from a lion, what does your body need? A whole lot more air, fast. Well, these drugs mimic that exact signal. They tell the muscles in your airways to just relax and open wide, a process we call bronchodilation.
And the star of this drug class, the one everybody's heard of, is albuterol. This is your classic rescue inhaler. Its whole job is to give you immediate relief during an attack. But because it's kicking your body into that fight or flight mode, it can also rev up your heart. That's why common side effects are fast heart rate, feeling jittery, or palpitations, and why doctors are careful with it in people who have heart problems.
All right, our next group of airway openers gets to the exact same place but takes a totally different route. These are the anticholinergics. They work by blocking the other side of the coin, the parasympathetic or rest and digest system. Now that system normally tells your airways to tighten up a bit. So if you block it, poof, the airways relax and open up.
The key player here is ipratropium. This one is used more for long-term daily management, especially in COPD. And what's cool is its side effects make perfect sense. If you're blocking the rest and digest system, you might get a dry mouth, feel a little nervous, or even have trouble with urination. It's all connected.
So prying the airways open is great for an emergency, but what about the root of the problem, that underlying inflammation? That's where inhaled corticosteroids come into play.
These guys are not bronchodilators. Their job is to go after the inflammation itself, to reduce the swelling that's causing the airways to get narrow to begin with.
Budesonide is the perfect example. And if you remember one thing from this section, make it this. This is a maintenance drug. It is not a rescue inhaler. It can actually take 2 or 3 weeks to build up to its full effect. Using this during an asthma attack would be totally useless. It's all about prevention and long-term control.
Okay, now we're getting even more targeted. Inside that whole allergic cascade we talked about, there are these specific troublemaker chemicals called leukotrienes. They cause a nasty triple threat. They constrict the airways, they ramp up mucus production, and they cause swelling. Well, these drugs work like a key that breaks off in the lock. They block the receptors for leukotrienes, stopping them cold.
Zafirlukast is the drug to know in this family. And again, you're probably noticing the theme here. This is for chronic management. It's slow to start working, so it's designed to prevent attacks over time, not to stop one that's already in progress. Now we're getting into some really advanced stuff. Immune modulators. These are incredibly sophisticated. Instead of just dealing with the aftermath of inflammation, these antibody-based drugs go way upstream. They go right to the source and try to stop that whole allergic cascade from even getting started.
Omalizumab does something pretty wild. Remember those IgE antibodies that are the first domino to fall? This drug is designed to find them, grab onto them, and basically take them out of the game before they ever have a chance to trigger those mast cells. It's a game changer for people with severe asthma. But that incredible power comes with a pretty serious risk we have to talk about.
You know, as they say, with great power comes great responsibility. And in the world of medicine, that means you have to understand the risks. These drugs are lifesavers, they're life changers, but some of them carry very serious warnings that we absolutely need to unpack.
And the biggest, most serious warning of all is something called a boxed warning. When you see this on a drug label, it's basically the FDA putting up a giant, flashing neon sign that says, "Stop, pay attention. This drug has a major, potentially life-threatening risk you need to know about."
And these aren't some super rare thing. Over 400 medications in the US have one. It doesn't mean the drug is bad or can't be used. It just means the decision to use it has to be made very, very carefully, weighing the benefits against those serious risks.
Which brings us right back to omalizumab. And here it is. Its boxed warning is for anaphylaxis. And you have to see the intense irony here. A drug designed to prevent allergic reactions can itself cause the most severe, life-threatening allergic reaction there is. Anaphylaxis is a full-blown medical emergency that can kill you in minutes. Okay, so let's pull all of this together. What are the big takeaways? First, diseases like COPD and asthma are all about two things: inflammation and narrowed airways. Second, our drugs are the heroes that either force those airways open or calm the inflammation down. Third, you've absolutely got to know the difference between rescue drugs for right-now relief and maintenance drugs for long-term control. And finally, with powerful drugs come powerful risks, and we have to respect that.
And that really leaves us with this one last thought to chew on. We've seen this whole incredible arsenal of drugs that can manage symptoms, prevent attacks, and drastically improve people's lives. But not a single one of them is a cure. They are all just tools to manage a lifelong condition. So how does that fact, the reality of management versus a cure, change how we think about tackling not just respiratory diseases, but any chronic illness?